Welcome back. So where we left off, we were talking about enteral tube feedings, and you can place a tube through a small opening in the abdomen, and it will feed directly either into the stomach or into the small intestine. If it's going into the small intestine, it's going into the duodenum, and then it is called a J tube or PEJ, which is a percutaneous endoscopic duodenostomy. If it's going into the stomach, it's considered a G tube or a PEG, or short for percutaneous endoscopic gastrostomy. If you would like to take a look at what some of these tubes look like, I can definitely show them to you, or you can ask any one of the monitors in the CLC, and they will be able to give you examples and show them to you of what they are. I do have some in the classroom, but unfortunately, I am not there right now. You could ask if you're going to the classroom on our normal class day. You could ask to see if Karen would get them out for you. They are in the classroom in the back. Dumping syndrome. This is one of the reasons why we don't want to do a bolus tube feeding. Your stomach cannot handle a large amount of the feeding. And so what happens is your body says, you know what, just get rid of this all at once. Usually happens about 30 minutes after you eat. And people who eat normally without a J tube or a G tube or an NG tube will have dumping syndrome. You may have experienced this at some point in your life. About a half hour after you eat, you get horrible stomach cramps. And because of that vasovagal response of your body wanting to get rid of it, you get that horrible sweating, the bad cramps, the shaking. You may feel nauseous, and everything comes out. Everything that you have eaten 30 minutes before and everything before that just comes on out, and you walk out of the bathroom being, I swear, 5 pounds lighter. So this can happen to anyone, but we don't want it to happen, so no bolus feeding, please. So what we would like to do is do small amounts of feeding. So usually we will say 240 milliliters or less in one bolus, or we will do a small amount of a drip over time. So it's kind of like a IV tubing, and it's hooked to a pump, but it is a pump for tube feedings, and it gives a small amount over time. So you will just take and dump whatever your liquid tube feeding is into a bag, hook it up to your either J tube, your G tube, or your NG tube, and it will distribute that over 8 hours or 12 hours or whatever you set it for. People who are on long-term G tube or J tube feedings, they'll usually do it at nighttime, so they won't eat anything during the day, and then all night long they're getting this tube feeding that goes in. All right, so when we place an NG tube, and please watch the video. I realize it is an older video, and I do apologize for that, but please do watch the video if you haven't done already. After an NG tube is placed, so we put the tube into the nares, and we push it down their throat into their stomach. Once it is there, what we need to do then is we need to mark how long the tube is from the end of the nose to the end of the tubing. So on our NG tubes that we will be using, it's the end of the white part, not the little cap that sticks inside of it, but the end of the white part of that tube. You want to measure from the end of the nose to the end of the tube that sticks out of the patient. That's what we want to measure, not the amount of tubing that we shove down into them. That's not going to do us any good. We can't see that. So mark from the end of the nose to the end of the white of the tubing, and mark that down, how many centimeters that is. Your patient will then, after you place the NG tube and you verified gastric contents by using a Toomey syringe, which is a large 60 cc syringe with a Toomey end on it, so it has like this little funny end on it that fits into the end of the tube. You aspirate back and aspirate gastric secretions, put it onto a little piece of litmus paper so that you get a pH of 0 to 4. You know that you are in the right place. If it's over 7, you may be in the lungs. So you really don't want to put any tube feedings into somebody's lungs. But once you have it marked and you have verified, and then you tape it into place, what you want to do then is send your patient to X-ray. Or X-ray can come to the room. Anyhow, they'll do an X-ray, and then they will be able to see, because all of the tubes are radio opaque, they'll be able to see where that tube is actually lying inside of the stomach. Every single time before you start a tube feeding using an NG or an OG tube, you are now going to take and re-measure to make sure that tube has not become displaced. Re-measure from the end of the nose to the end of the white part. Even though it is taped in place, it gets very gooky and icky, and that tube can go through that tape, and you think it's in the right place, but it's really not, and you're actually going to be putting tube feeding into somebody's lungs. So make sure that you verify that it is in the right place. When doing your validation, make sure that you look at the doctor's orders. Make sure that you are looking to make sure that the tube feeding is the correct type. Please, please, please do not open any of the cans or bottles that you will be using for your tube feeding. Do not open any of the Ensure or Isomil or whatever it is that you have. They are expired by sometimes several years, and I imagine that does not smell good. We are only going to take and pretend that we are doing it. So you're going to show them exactly what you would do. You will also, if they've had tube feedings before, you will measure for any kind of residual tube feeding that they may have. So what you will do is you will aspirate, and if you are able to aspirate 200 milliliters of tube feeding, you will give that tube feeding back to them. They're going to need it. So give it back to them, and then wait. And you're going to wait for at least 30 minutes to an hour. Come back, do it again. If you get over 200 milliliters twice, that tube feeding is not going through, and you've got an ileus, which means that your small intestine or large intestine has stopped. It's actually quite painful, and you do not want to give them any more tube feeding on top of this. So hold it, then call the physician if you get residual over 200 milliliters twice. Always make sure that you elevate the head of the bed, and then make sure that they are elevated at least for 30 minutes afterwards, after you've done the tube feeding. You're also going to assess for bowel sounds before and after tube feeding. And of course, make sure that you listen on the skin, not over the gown. Again, make sure you check that tube placement. Check it again. We've actually had students who did not check tube placement in the clinical setting, and the patient did aspirate. Don't let that happen to you. Make sure you test that tube placement. You're going to, when you pull that tube feeding out, make sure that you check the expiration date. Alcohol off the top of the containers. Believe it or not, those containers are in warehouses where there are rats crawling all over it and there may be feces. So make sure that you alcohol the top of those containers off. Before we put anything into a tube feeding, you're going to flush with 30 milliliters of water beforehand, and you're going to flush with 30 milliliters of water afterwards. If you are giving medications, you will crush those medications and you will mix each medication with 10 milliliters of water for each pill or tablet that you are giving. So if you're giving 3 tablets, that'll be an additional 30 milliliters of water. So on your I&O, if you have somebody who is on I&O and is on tube feeding and you're giving them 3 tablets of medication, their total I&O for that will be 90 milliliters, 30 before, 30 with, 30 after. Make sure that you look at the policy and the procedure that's outlined for you. Make sure that you look at the learning module and please watch the video. And again, this is the medications that you can do for each one. Of course, we're not going to crush enteric-coated or extended release medications. Make sure that you record your I's and O's on each one. When you are inserting the NG tube, you're going to make sure that you measure from the patient's ear, either the top of the ear or the bottom of the ear, it doesn't matter. So you're going to take the end of the NG tube, the end that will be inserted into the patient, and you'll measure from the ear to the nose and then down to the xiphoid process. Right now, I want you to feel for your xiphoid process. It is the end of the sternum, that little nub that's at the end of your breastbone or your sternum. That is your xiphoid process. That's where you are going to measure to. You will then take a small piece of tape for working in the CLC, because, of course, markers are not allowed in the CLC. But we are going to use a small piece of tape, put it around that area, and that is when we tell the patient to swallow and we start introducing the NG tube down into the stomach. That is where we will stop at the nose, is where you have that small piece of tape. When you are discontinuing the NG tube, just tell the patient to take a deep breath and then pull it out in one swift movement. Their eyes may water a little bit. Make sure that you have a basin there in case they need to vomit. I'm going to continue on with TPN in the next version. So this is going to conclude the second part of this PowerPoint. Please stay tuned for the third part.